for interview today. You are president and scientific director of the Laureate Institute for Brain Research. You're a psychiatrist, and you're also an academic with over 300 scientific papers published over some time. Welcome to our interview today.
Thank you for having me, very nice to be here.
Yeah. So tell me a little bit about what's really cutting edge in interoception research at your institute. What is the research team up to? What are you particularly interested in?
Mm-hmm.
Yeah, go ahead.
Yeah, so, I've been involved in interoception research for almost, let me think about this, over 2 decades now. And what started out as being an interest in trying to understand what the insular cortex was doing in the brain and how it was contributing to how people were behaving, turned into really a multifaceted program of research. There's a number of people at the Institute and people who were at the Institute now at different places are still pursuing. Part of the problem with interoception, it's almost true for almost any construct. It's intuitive on some level. It's sort of the internal state that is being sensed by the body, and that influences how we behave. But the measurement and also the formulation and making it quantitative and making it so that you can actually make a more precise prediction has been a challenge. And so, we've tried to do different things. We've developed paradigms that allow us to assess different aspects of interoception. So we expanded the heartbeat perception task to do various levels of assessments. Can you feel your heartbeat? If you can feel your heartbeat, how accurate is the feeling? How accurate is it compared to something that is not feeling your heartbeat? We've also expanded on a paradigm that a previous member of the Institute had developed that was primarily focused on neuroimaging, trying to focus on interoceptive attention, and that has helped us to kind of map out different ways of how the insula contributes to behavior. But more recently, and over the last few years, what we've tried to do is develop a computational framework. And the idea there is what you're trying to do is you're trying to pair interoceptive processing with a behavioral paradigm that allows you to estimate parameters that describe the degree to which you're processing interoceptive information. And so what we're currently doing, and this is Ryan Smith at the Institute, we've developed a paradigm that is very much like something that has been used in the exteroceptive world for the interoceptive world,
Interesting.
where we're using various levels of interoceptive perturbation, and we're using what's called the breathing load. It's a very it has it as its advantage that you can manipulate it parametrically. So what we're doing is we're making it momentarily more difficult for you to breathe in. Human beings are very sensitive, for obvious reasons, very sensitive to that. And what we're trying to do is in a number of years ago, there was a paradigm that had been developed to look at how people potentially develop hallucinations.
Yeah.
The idea was where, like if you hear some noises and maybe a crowd of people with muffling speeches, can you hear a word? And can you hear a word that you feel confident that you can hear? And so the idea was that what people are using this paradigm for is to help understand how the brain processes hallucinatory events. And then what we've done, we've taken this to the interoceptive world. The idea here is that we're ever so slightly basically make it difficult for you to breathe, and we're asking you interim, oh, are you feeling anything different? And so
Like a tightening in the chest or something?
exactly. And
Yeah.
but we're asking you whether we changed anything or we didn't change anything.
For
See what I'm
accuracy,
saying?
just going back to that.
So to basically evaluate in a quantitative way,
Yeah.
are you actually perceiving what you're perceiving, what you think you're perceiving?
Yeah. 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 Wow. Wow. Wow.
And and the reason for this is very important because many of our ideas around interceptive processing is that people have um, various level of sensitivity of the interception that is going on with them, and also have predetermined ideas of what the interception means in terms
Yeah.
of
Meaning made. Yeah.
what actions they should take. And so this is sort of a computational paradigm that allows us to probe for each individual how much they're influenced by their prior expectations of that they should be that they experience something. Because the idea is that if you have a high prior that you're being an interoceptive challenge, you're much more likely to say that you were interceptively challenged when you were not.
Interesting.
And and we can make that we can make that very precise with this paradigm. And so the reason why this is important is to try to really get a better grip on how precisely interception influences behavior. I mean,
Mm.
it's intuitive that when we're in different interceptive states, we have different motivations. We're cold, we want to be warm. If we're warm, we want to hot, we want to be cold. If we're hungry or starving, we want to eat. If we, so it's intuitive, but measuring this is actually a significant challenge. And there are different groups around the world that are working on this. But the reason why that is important is because to make interception really meaningfully beyond just metaphorically contributing to motivated behavior, we have to really precisely understand how exactly it does influence the behavior and how that might be different in
Mm.
people with psychiatric conditions.
Yeah. Yeah. And do you see a correlation with, for example, ACEs, so adversity, trauma, maybe the epigenome, the genome, from birth, and how then that influences accuracy, awareness. I think you called it attention.
Yeah, that's a good question. So the early life trauma has really complex effects on many processes. We know that early life trauma results in greater risk for anxiety, depression down the line. We know that inflammatory processes are affected by early life trauma. So part of what we're looking for is um, how precisely does it affect, for example, the bias of whether an interceptive sensation is evaluated as being positive or negative.
Yeah, in terms of the
And
valence. Yeah, yeah, yeah.
because, for example, for say, for example, let's say with the air for a moment, let's say I have a momentary sense that I'm not getting enough air. That could make me panic, or it can make me want to breathe harder. So, for example, if an athlete feels that they're not getting enough oxygen, they're breathing more
Yeah,
because they need more oxygen. But if somebody feels like, oh my God, I can't breathe, they may have an anxiety attack. Now, the question is whether the biases that might be set up because of early life
hmm,
trauma, um, are they um, set us up to be more on the panicky side than on the reactive side? Okay, I need to breathe more. That's still an open question. What's difficult, and again, this is difficult with all of these assessments. Early life stress is often evaluated retrospectively, right? So I
yes,
ask you, for example, using the childhood trauma questionnaire, did you experience X, Y, and Z? And we know that when people are answering these questions, they're answering these questions with the current mindset.
that's right.
And so sometimes that may mean that they're either not reporting or reporting more extensively what they're experienced, because it's their experience that they currently have that determines what they've experienced in the past. Um, we have there's beginning studies now, like for example with the HPCD study, where literally thousands of kids are being followed from very early on till during the first decade of life, and then also we are part of ABCD, where we also have stress measured during the second decade of life. Um, that it's going to be really important in the future to have prospective measurements where
Mm,
we really know what actually are the experiences that people have had, in addition to what they're experiencing going back. Because in a sense, you can see that it's very hard to de-link
that's right.
what you're currently experiencing from what actually happened during your early life.
Yeah, yeah. Do you think, I'm going off script here because you're saying so many beautiful and interesting things, but do you sort of think, with your research and experience that that's sort of, it's more like a top-down process of kind of meaning making? Because obviously people would be in different states depending on, right, if I see someone at 7, if I see someone at 10, 13,
Yeah.
21, although, we're going to be in different states, right?
Yes.
Different states can have different meanings for then how we interpret our bodily
Exactly.
sensations. Yeah. Is that what you're
Yeah, I
saying?
think in effect, it's actually, even though it's more specific to what you're asking, it's more specific to stress and early life stress. It's actually also the same principle applies to interoceptive processing, which is the idea that we're not just sensing things coming in, and the whole anatomy is set up that there is already an expectation of what the senses should be
Ha.
and how the senses should be interpreted. So sensing doesn't happen in a vacuum. It
Mm,
happens in the context of an expectation.
prediction.
So if you look at simply the anatomy of what processes interoceptive afferences from the body, it goes through various way stations, ends up in the insular cortex, mostly trans from the posterior into the anterior insular cortex. The anterior insular cortex is a critical way station from receiving afferents from many different parts of the brain, and is connected through these large scale neurons that connect to all parts of the brain, and is ideally suited to integrate and to process information not just in isolation, but in the context in which I'm expecting
Mm.
the sensing to be. Am I in a dark alley where I feel my heart beating? Am I at a sports event where I'm excited about my sports team? In both cases, the afferences might be actually quite similar. However, the interpretation of these afferences is very different.
Yeah, yeah. And I think what you're talking about is some of Professor Liesman Feldman Barrett's work. She says something along the lines of, every moment is a combination of the remembered past and the
Mhm.
sensory present, because you've got that kind of prediction set up as well as the
Yes.
here and now sensing of interoception, exoreception, and how it's all coming
Yeah.
together. It's complex.
Yeah, it's her basically her hypothesis is that what we're doing, we're constructing our emotions.
Yeah.
That we're getting afferences that signal to us how our body senses its homeostatic state, but we're interpreting these afferences within the context of what we've experienced in the past, plus what is currently around us in a exteroceptive sense. So yeah, and then the emotion that comes from that, whether it's fear or excitement, is a consequence of that interpretation.
Yeah. And how do you see sort of that interception awareness and accuracy helping the predictive mechanism as such, if you see what I mean? Like, for example,
Mhm.
clinically, if we work on accuracy and awareness, obviously awareness first, then accuracy, there's the correlation. You know, do people's experience and therefore mental health issues with substance misuse, addiction, anxiety, depression, is there a correlation with sort of symptoms getting better or not? Or
Yeah, I mean, I give you an interesting example, very kind of self-related to some extent. So, say you are, say you're traveling, and you're having to catch a connecting flight, right? I've traveled very extensively, but I still get nervous. I still feel my arousal going up, and it even though, from a predictive stance, I know that in very rare cases, if ever have I have I ever missed a flight or missed my connection? When it obviously can happen, but it's very, very rare. And yet I interpret this to mean, oh, I'm really anxious at this moment.
mm-hmm.
So the idea is that if you put this into a framework of what the interception that what's happening is you have the context, which sets up a conditioned situation. You have experiences that you are aware of, say your breathing or your heartbeat or some kind of nervousness, and then you interpret this to be, oh my God, I'm going to miss my flight. So the first thing is to notice that you have these experiences, right?
Mm,
That's your body doing its computation, but and this is where the therapy then comes in. You can reinterpret these experiences, and you have to recognize that you have to repeatedly make these reinterpretations. It's not like, oh yeah, I understand this now and it's different. That's not how you have to basically um, uh, you have to repeatedly expose yourself saying, okay, what my body's doing, it's doing a computation about future events. It can't predict those future events. That's why it increases arousal.
mm,
These arousal experiences, for a number of different reasons, are evaluated negatively. That I interpret as anxiety. But if I stand back, I can look at all of these components and I can understand, and it can help me to decide, oh, I can, the arousal level is just simply me getting ready to go from point A to point B through maybe a busy airport or this, that, the other thing. Um, so uh, it can be a focus of a behavioral intervention
mm,
that can help eventually for the person to be better adapted to the stress that might be experienced in, say, in this particular situation or in any other situation that
yeah.
where you have the body state signals you something, and your top-down experience interprets it in a certain way.
Yeah, yeah. That's really interesting because kind of what I'm seeing, I'm just sort of like just, brainstorming here, which is about, yeah, if we change some of the meaning made for interoceptive signaling internally, for example, in situations like running through an airport, for example, what happens if your meaning made was this is great, I'm going to sit in the lounge, I'll have a nice meal on board, maybe do a little bit of work, have a half an hour nap, I'll then land, and you're thinking fabulous experience. I wonder if we change the meaning, would it then have an impact on then those bottom up interoception processes, for
Mhm.
example lowering arousal? Don't know, just a
Mhm.
question. I don't know, maybe your thoughts on that.
Yeah, so because the system works interactively, right?
Bidirectional.
If you if you- I mean, again, let's go back to the example of the dark alley versus the sports stadium. In the sports stadium, you get aroused excitingly about your sports team, and you savoring that moment of say a score or whatever. In the dark alley example, you're getting aroused, but you're getting aroused out of anxiety. Maybe there's somebody following me. Maybe I'm in a
Yeah.
dangerous situation here. The way that you can then help reinterpret the arousal state can make a big difference on how you act subsequently. Now, I'm
Ah,
not saying that you don't want to get excited about being in a dark alley, but what I do want to say, you may be in a situation that maybe perhaps is neutral or maybe not as
exactly.
dire as you would think, and you reinterpret this, that allows you to say, just like what you said, okay, maybe I missed the flight, but then, they'll automatically rebook me and I can, do some work or listen to an audiobook or do, whatever it is that you're doing. The point here is, and this is the key element of adaptive behavior. Adaptive behavior means that you have more options to do things that you normally might not do. It's easy to see this, for example, in addiction.
Yeah.
Addiction is a highly maladaptive behavior because it funnels all actions towards either getting the drug, experience the drug, or getting over the withdrawals from the drug, right? So it's basically everything is focused on that. No friends, no recreation, no nothing. It's all. So your behavioral repertoire is extremely limited. And so the point is you're trying to open up the behavioral repertoire, but that, I mean, so you may, for example, have to experience adverse behavioral states, arousal states that come from withdrawal or
Mm.
that come from, not being surrounding the people that you're normally surrounded by, whatever it is. But the point here is you're trying to basically make your behavior more adaptable so that that it isn't just one thing that you do that gets you that gets you out of the habit. Now it's difficult because in a case of addiction, of course, there are multiple neurobiological pathways
Yeah.
that have converged onto this one behavior. So, you may need more than just a behavioral intervention, but the point being is the ultimate goal is to broaden behavioral repertoire.
Yeah, yeah. And with that, I think what you're alluding to is that if an individual is a patient's able to do that, for example, in addiction, that change of neuroplasticity, right, because we're
Mhm.
changing neural pathways, perhaps has some effect on interoception signaling, as in,
Yeah, yeah, that's a good question. So we've done some studies in particular with anorexia, people with anorexia, and found that they at particular low or no stimulation, they have uh, what they feel as aversive signaling. So
ah,
they have maybe increased sensitivity to these afferent signals. So the point would be, can you reduce the sensitivity to potentially false afferent signals? And then negatively, because they evaluate a lot of the GI signals as negative
mhm,
because, because it helps them to maintain the behavior of
restriction.
not, eating. Um,
Mm,
but can you make those signals, those potentially sometimes these noisy signals, can you make them less noisy so that you could differentiate what is truly a signal that I need to pay attention to versus a signal that just comes up, because my body always sends some signal. So the differentiation between what do I need to pay attention to in terms of body signals and what can I ignore because it's a noisy signal is going to be very important as well. We posed this many years ago, Murray Steen and I, that anxiety in many ways is sort of a signal to noise failure. That interoceptive signals are sensed that then are interpreted. Oh my God, something bad is happening. When in fact, it's just your body sending you signals all the time. And sometimes it's good to pay attention to them. Sometimes it's good to say, notice them and just let them go, which is why it's not always good to pay attention to your interoceptive signaling. It's also not good to not pay you. It's the
valid.
differentiated view within the context of what you're finding yourself in. For example, coming back to the breathing, there are cases of individuals with severe asthma and we don't fully understand this, they can't sense that they are in severe respiratory distress.
Wow.
And for those people, it can be almost deadly where they can be, severely hypoxic and they just don't notice. Now,
Right.
there are other people who feel that they're severely
Nothing
hypoxic
wrong.
and they're not. So the point being is that it is really trying to match, uh, uh, your attention to what is necessary in the particular situation. Sometimes we're paying too much attention. Sometimes we're not paying enough attention.
Yeah. What do you think is in your view, is some of the factors that might cause more sensitivity to the noise internally? So one's difference in perception related to bodily signaling.
Mhm. Yeah, that's a really good question.
That
And part
arousal or like sympathetic arousal? Is it sympathetic arousal or something else?
Well, so it's certainly sympathetic arousal is sort of the description of the state you might find yourself in as a consequence of having interoceptive afferences, like breathing hard and other things. But it comes back to the experiment that Ryan Smith is setting up. One thought and one and that has also influenced Lisa Feldman Barrett's work is the notion that what we're trying to do is we're trying to reduce uncertainty about future states. In other words, and this is sort of in the broader context of a computational model of active inference. So our actions are geared to try to make the future as predictable as possible under the circumstances. And so the issue is that some uncertainty is fundamentally irreducible.
Mm,
You can't make that go away. But and you can see, and now we're coming back to your original question of what might early life stress contribute to the processing of interoception downstream. One element of early life stress, of course, is that there are many things that are unpredictable and uncontrollable for a
mm,
young person. And so, but at that time is also not reduced because you're not the agent creating the chaos, creating the mayhem. You have no way of reducing that uncertainty. Yet, your brain is basically being trained to try to reduce something that is not reducible
mm, mm,
in terms of uncertainty, because again, you don't have control. You can't remove yourself from the situation, which as an adult you might. Um, but that computational principle is then still presumably working as an adult. You're trying to reduce uncertainty at a level that you can't reduce. So you're expending a lot of computational cognitive effort to try to figure out how to act on something that you can't reduce or you can't control in a sense. That's where the signal to noise comes in. If there's noise, true noise that is non-informative, if you act on that noise, it doesn't help you to become more adaptive.
mm,
And the idea is to change that computation. Now, again, a lot of this is still hypothetical. That's why we need these computational approaches to estimate these parameters so we can make this quantitative and make it more precise. But that was sort of the original idea that what we're needing to do is in an anxious person that's trying to reduce uncertainty that can't be reduced, is to allow the existence of that uncertainty to not result into a kind of brain state that makes the person panic. Oh my God,
mhm,
I can't live with that uncertainty. Because the truth of the matter is, we all live with uncertainty all the time. We have different sensitivities to with which we are processing that uncertainty. If you go into, say, you go into a shopping mall, or you go on a Christmas market, or there'll be random events you have absolutely no control over. Yet it's not like you worry about this. You may not, some other people might very well worry, but the point being is we deal with uncertainty that is uncontrollable all the time. Our brain has the ability to to see that as arousing, but not as panicking.
Yeah, yeah. This isn't a trick question, but while I've got you, I just wanted to ask because you might know the research behind this. When um, children in utero, children are have that uncertainty, and say, for example, is pre-verbal, so we're looking at babies, toddlers, um, without vocabulary. So I'm just sort of thinking of, patients who maybe were abandoned at birth or they were put up for fostering and adoption. Is there data or research to suggest that those if meaning is not made because the human is not at a developmental stage where meaning can be made, that there are processes happening in the brain that sort of set up that that neuroplasticity to create the noise? Or do you think at some point in the lifespan meaning is then made to the noise? Do you see what I'm trying to say? Yeah, yeah.
Yeah, yeah. Well, I mean, so it's hard to. I mean, this is a very, very difficult question
Mm,
to address because it's hard to have the counterfactual, right? So what you would have to have is a baby that stays at that stage, so that you can see what the subsequent meaning production
I
does
see.
to that original stage.
Mm,
But let's take another example, for example, where we might be able to. Let's say you are a child
yeah.
and you later become a parent.
Okay.
And you have a perspective of your parents as a child, and then later you're a parent, you have a parent perspective on your child.
Yeah.
So in a way, one way to think about it is as a child, you see your parents in a certain way, and they have a certain influence on what you do, and you have a certain affective and interoceptive response to it. As a parent, you are on the other side. So your meaning making can affect the experience that you've had as a child because now you're a parent, you have the other side. So the point being is, I think meaning making occurs throughout our lives in reinterpreting
Yeah.
events that happen to us early in life, maybe even preverbally. Right? That's a hard one to test because we don't have but we do see that as people go through different stages of life, have different experiences, they reinterpret what happened to them uh, in the past.
Yes, yes. I'm conscious of your time. I know that you're very busy. I just want to ask two more questions. One
Mhm.
is around optimizing medication treatment for maybe with your expertise, sort of dulling the noise, or say a little bit more about where the current research is at, SSRIs, benzodiazepines, etc.
Yeah, it's a good question because there's a couple of elements with medication. The first is the intended effect, and the other one is the non-intended effect. One of the things that we all know is that, particularly in the beginning, many medications have unintended effects, right? For the SSRIs, it often has GI side effects. It can make people, internally restless. And those are clearly, I mean, these have been well established. And of course, sexual side effects is another element. Um, so the point is, can you work with a person to again not um, basically reduce or eliminate these side effects, but just basically put these side effects into perspective. What does that mean? It means, okay, the medication is on board. It's doing what we know it can do. Um, Now, if it's terrible, if the side effects, if the unintended effects are so strong that the person can't function,
Mm,
then clearly you want to, look at something else. You want to change medication. On the other hand, we also know it does take a while for the intended effect, the antidepressant effect, to take effect, and therefore there could be a payoff a little further down the road. So the first thing is to work with the patient to see, okay, I leave it up to your judgment. You experience these effects. Is it possible to give yourself, 4 to 6 weeks to reinterpret these effects as a necessary interim? if the downstream effects are positive. The second thing is, and this happens quite frequently too, people come back and say, it's hard for me to feel anything
Mm,
because, everything seems to be dampened down. Then the question is this, is this something that is truly a sensing that it's stemmed down? Is it that again, we talked earlier about that any sensing is a combination of what you're expecting and what you're receiving. The question then is it and for some people is it so concerning that they don't see themselves as being who they were and therefore they don't want to continue with the medication? Or is it something that one can work with in terms of modifying the experience? Are there other things that they can expose themselves to that get them excited, that get them
yeah.
positively balanced? So the idea is if you have this, top down, bottom up uh, uh, kind of framework, you can use it both for the unintended effects, the side effects, as well as the intended effects, ultimately to determine, does the medication do and help the person to be in a better position down the line, less depressed, less anxious, more able to go out and experience things. For example, for socially anxious people, can they engage with others? For people with panic disorder, can they go in the open space without having a panic attack? For people with depression, can they go and listen to a concert and enjoy the concert? Ultimately, it's the functional outcomes, from my perspective, that count, that you want to optimize with patients.
Mm. Last question. Regarding interoception research, and maybe the clinical application of that with yourself as a psychiatrist, is there anything that we haven't spoken about today that you would like to say? Yeah, maybe your personal view or where the institute is at.
Yeah, I think that and you touched on that a little bit. You talked about how we might influence interception directly in various means without talking to a person, right? I
Mm,
mean, that we're so used to using verbal action to influence each other.
yes.
And so what we're doing is we're beginning to, um, we've done already a little bit of that. For example, we have a group that is doing flotation research where
I
what we're
saw that.
doing is we're removing extraceptive input so that people experience only interceptive afferences. And that can be very, in a safe environment again. We've done this with anxious people and we've done it now with eating disorder people. It can be very soothing and very, very helpful in reconnecting to interception in a safe
Wow.
and a non-panicky type of way. But there are other ways of how you can expose yourself. There's some, we're just beginning to think about, stress-related disorders which have, lots of hyperarousal, lots of disconnection between the interoceptive afferences and the top-down modulation. So we're thinking in terms of exposure to green spaces or exposure to nature,
Mm,
which is another way of how you can uh, put yourself in a different sensing context.
yes.
So uh, I think that there's more work that needs to be done to try to modulate the interoceptive system beyond verbal behavior and beyond medication. Now, these are
Mm,
important. I'm not saying that they're not important. A third one is exercise, right? I mean,
mm,
we know exercise is in very, very important way of improving your mood, and yet we have very little mechanistic understanding how that actually how it actually does that.
mm,
So these are so the flotation is one, the exercise is another one, and then exposure to green space, putting people in different states as a way of changing the interceptive state to ultimately improve a person's outcome. I think that's sort of where we are with various groups at this point in times.
mm. Dr. Martin Paulus, really appreciated your time today. It's been a pleasure and an honor to have this time. Yeah.
Thank you for having me, Tracy, and hopefully you have a wonderful holiday and a great start into the next year.